Hi, my name is Dr. Michael Stany, and I'm a practicing GYN oncologist in the Washington metro area. I'll be talking to you about the diagnosis of a pelvic mass and what that means and what kind of evaluation and treatment goes into that. A pelvic mass is a diagnosis that just means that something in the pelvis is found. And how is that found? Well, oftentimes this is something that's found incidentally, meaning that if you have an imaging study or some evaluation for something else, that study also shows that there's something in the pelvis. Or it can be found as an evaluation for pelvic pain or abdominal pain. So regardless, when a pelvic mass is found, it is something that when it's found, is usually referred to a GYN oncologist. So we'll talk about what that evaluation is then. But of course, the first question is, well, what is it? What could it be coming from? Well, there are many organs that are in the pelvis, and one of those includes the uterus. And a very common finding within the uterus are fibroids. Fibroids are benign muscle tumors, and in fact, almost half of all women have fibroids. So this is a very common finding. Fibroids can vary in size from a few millimeters to many centimeters, 10, 20 centimeters. They can be very large in size. So this is a very common finding, a very common reason why somebody would have a pelvic mass. The other organs, of course, include the ovaries. And among abnormalities of the ovaries include benign cysts, and there are many, many different types of benign cysts that can arise within the ovary. Of course, another concern is ovarian cancer, and that's why us as GYN oncologists oftentimes evaluate a pelvic mass. Other organs include the fallopian tubes. Sometimes fallopian tubes can be dilated and present as a pelvic mass. And lastly, the bowel and the bladder are also pelvic organs, and abnormalities arising from these organs can present as a pelvic mass. So as you can see, there are many organs in the pelvis, of which there could be many causes for the pelvic mass. So when a patient is referred to a GYN oncologist for a pelvic mass, there's a fairly standard evaluation that we do. We ask the patient many questions. We determine what their age and menopausal status is, because that kind of helps us determine our level of concern for what's going on. We also do a very detailed exam, a physical exam, and specifically a pelvic exam, and usually a rectal exam. And the reason for this is that we're trying to understand the size of the mass and how it is in the pelvis in relation to other structures. Is it very mobile? Does it move around, or is it stuck to other structures in the pelvis? This helps us from a surgical planning standpoint, where we can make the decision whether or not this is something that, if we need to do surgery, we can do it through small incisions with the laparoscope. Or maybe it's a large mass that's very fixed, and the safest way to go about surgery is making a larger abdominal incision. So that's why the physical exam is very important when we're evaluating a pelvic mass. Oftentimes lab work is also needed. Oftentimes go to CA-125. Sometimes patients have already had a test called an OVA1 done, and we'll talk about that in just a minute. And then sometimes, while patients have already had some imaging studies, additional ones are needed. These include either a CT scan, an MRI, or an ultrasound. So regarding some of the specifics of the evaluation, menopausal status is something that we pay attention to. The reason being is that the average age of patients with ovarian cancer is 63 years. And so the majority of patients who have ovarian cancer are postmenopausal. It can happen in premenopausal patients, but it's very rare in women who are under the age of 40. Now, women who have not undergone menopause do ovulate, usually on a monthly basis. And oftentimes the pelvic mass can simply be related to ovulation, where every month a follicle develops within the ovary, and if there's some bleeding into the follicle or ovulation is not complete, the cyst can persist and oftentimes present as a pelvic mass. So in a premenopausal patient, the ovaries are dynamic organs that change on a monthly basis, and that's a very common reason why women can have a pelvic mass. In the postmenopausal setting, the ovaries, are not ovulating, and so we pay a little bit more attention to abnormalities when they are in the ovary. Now regarding lab work, I mentioned the CA125. The CA125 is a biomarker, which means that it's a protein that's level is measured after a blood test. The CA125 has been associated with ovarian cancer. And when I say associated, I mean it's not a perfect test, meaning that if it's normal, that doesn't necessarily rule out ovarian cancer. And in fact, you can see from our first tab here that only half of patients who have a stage 1 ovarian cancer actually have an elevated CA125. So again, a normal value doesn't necessarily rule out ovarian cancer. But on the flip side, an elevated CA125 doesn't necessarily mean that a patient does have ovarian cancer. As you can see, there are other benign reasons why patients can have an elevated CA125. These include endometriosis, fibroids, and then other various inflammatory disorders. Now, we're talking about isolated values there. Oftentimes, getting a trend of CA125s can help us when we're trying to determine our level of concern with the pelvic mass findings. So a patient can sometimes have a CA125 with their first office visit and then have that repeated 6 weeks, 2 months, 3 months down the road just to see if there are any significant changes with that as we're trying to sort out what to do. Another lab test that is sometimes obtained with the finding of a pelvic mass is an OVA1. And this is a series of biomarkers that include a CA125 plus 4 other biomarkers. And again, these are proteins that are measured from a blood test. In 2009, the FDA cleared this test, the OVA1, to help improve the predictability of determining whether or not a patient has ovarian cancer. And these are patients who are already undergoing surgery for evaluation of a pelvic mass. So this is a test that's helpful mainly for general gynecologists when they have a patient with a pelvic mass, when they're trying to determine whether or not they should do the surgery, or if this is a patient that should be referred to a G1 oncologist because perhaps there's a higher chance of there being an ovarian cancer. If a patient has a high likelihood of ovarian cancer and they end up having that with surgery, it's better that they have their first surgery done by a G1 oncologist just so the right kind of surgery is done. What we call a staging procedure where biopsies, removal of lymph nodes, and other things are important for that initial surgery. As you can see from our last tab here, the OVA1 test generates a number from 0 to 10, and there's a different cutoff between premenopausal and postmenopausal patients for defining what that high probability of malignancy is. So if a patient has an elevated OVA1, usually they are referred to a G1 oncologist for further management. Again, just like the CA125 by itself, an OVA1 is not an absolute indicator of ovarian cancer. Again, it just gives a higher likelihood of ovarian cancer. So we talked about blood tests. Next we'll talk about imaging studies. A pelvic ultrasound is oftentimes obtained when a patient has a pelvic mass. The ultrasounds give very good images, very detailed images of the ovaries and the uterus. And an ovarian cyst is, again, a very common finding with the diagnosis of a pelvic mass. And among the categorizations of ovarian cysts, they include simple cyst and complex cyst. And the way I explain these to patients is a simple ovarian cyst is kind of like a water balloon. It's a very thin-walled structure that has fluid inside of it and really nothing else. That's a simple cyst, and that is not cancer. Many studies have evaluated that exact scenario, and just a simple cyst is not representative or predictive of ovarian cancer. Now, a complex cyst is the other categorization of ovarian cyst, and that's a very broad category with a large spectrum of findings, which makes it complex. So a complex cyst is really a simple cyst with something inside of it. So again, kind of like a water balloon, but it could have other things like an extra wall or septation within it. That's not too concerning of a finding. Or it could have more things, so blood products kind of floating around, could have some sort of masses or growths within inside of it, things that we call papillations or excrescences, sometimes look like cauliflower growing inside of a mass. Those are more concerning findings, and we'd be a little bit more worried about a cancer in that scenario. But a complex cyst, it might be cancer, but the majority of complex cysts are not cancer. Simple cyst, we are not at all worried about cancer. Complex cyst, there is the concern for cancer, but again, most complex cysts are still not ovarian cancer. Regarding CT scans, they're not very good imaging studies for looking at specifically the ovaries, but they are pretty good for looking at everywhere else in the abdomen and pelvis. So if a patient has, for example, a complex ovarian cyst and maybe has an elevated CA125, and we're a little bit more worried about ovarian cancer, a CT scan can help look at everything else. So look at lymph nodes, look at the bowel, look at the spleen, the liver, other places that we'd be concerned about potential spread of the cancer, and that would help us from a surgical planning standpoint. And lastly, an MRI is another study that could be obtained. It's a very good study for looking at the tissue of the ovaries and the uterus, and oftentimes it helps us with determining the origin of the mass. You know, is it coming from the uterus? Is it a fibroid, or is it truly an ovarian cyst? It is an expensive test. It's a very lengthy test, a half an hour to an hour or so. So usually it's not our first line test when we have a finding of a pelvic mass. Usually the ultrasound is a little bit better in that regard, but sometimes it can help us when we're trying to sort out what to do next. So after the first visit, if you're seeing a GYN oncologist for the finding of a pelvic mass, there's really only two avenues that we can go after that first evaluation. Either we determine that the suspicion for cancer is low and we can watch it, and that might mean future exams, future ultrasounds and labs. Certainly if the patient's not having any symptoms from it and there's a very low concern for cancer, then watching it over time is very reasonable. However, the other avenue might be surgery, and lots of different types of surgery, from minimally invasive to more open procedures, might be indicated depending on the characteristics of the pelvic mass. Reasons we would do surgery: if a patient's having significant pain and symptoms from it, or perhaps this is a mass that's been followed over time and it's still there, it's still getting bigger, that would be another reason to operate. And of course, if there are findings just at the initial onset that make us concerned that there's cancer based off the complexity of the ovarian cyst, that would be another reason that we would recommend surgery after the initial visit. Now, of course, when a patient is referred to a GYN oncology with a pelvic mass, the first question is, well, you know, is this cancer? And let's really determine that as quickly as we can. You know, can't we just put a needle in it and figure out what it is? And the answer to that is usually no. Unlike patients who have an abnormal mammogram and undergo a breast biopsy with a needle, you know, we usually don't do that for ovarian masses. And the reason for that is, if it is an ovarian cancer, you know, passing a needle into the ovary, you know, outside of a surgical setting, could potentially spread the cancer. And oftentimes that means that a patient would need additional treatments to include chemotherapy or other surgeries from that procedure. So there are certain scenarios, though, where we would consider doing a biopsy, but those would be select patients where perhaps they had a CT scan that was more concerning or consistent with metastatic ovarian cancer, and so we would be biopsying maybe fluid that was in the abdomen or some other mass that might represent a metastatic lesion. That would help us with determining surgery and chemotherapy and those sorts of things. But in the patient who has an isolated ovarian mass, usually we do not recommend doing a needle biopsy of that. So if there's truly a concern for ovarian cancer, usually surgery with removal of the entire ovary is the best management. And I said usually the best management because there are, of course, different scenarios where just removing the cyst or different management techniques are reasonable. Just in general terms, though, if we're worried that there's an ovarian cancer there, removing the whole ovary intact is usually the best management strategy. And so after that evaluation, of course, waiting can be the hardest part, either waiting for surgery or waiting for the next ultrasound or lab value or office visit. We can definitely appreciate that it's hard to wait. And as I mentioned in the earlier slide here, if we're really worried about cancer and trying to sort that out, well, surgery is the best way for that. But then we don't want to just operate on every single patient who has a diagnosis of a pelvic mass, because most of the time it's a benign finding, and many times the cyst, if it's an ovarian cyst, will resolve on its own. So we just want to make sure that surgical management is justified and corresponds with our level of concern for ovarian cancer. And while a pelvic mass can always be concerning for a cancer, specifically an ovarian cancer, just remember that really nothing is diagnostic of ovarian cancer unless the pathology report states that, meaning we've had surgery, we've removed the abnormality, we know what it is. Again, waiting is the hardest part, and we definitely sympathize with our patient along the way there. Again, my name is Dr. Michael Stany, and I'm a GYN oncologist in the DC area. Thank you for your time, and I wish you the best.